Hello everyone, welcome to my YouTube channel, Holistic, Palliative and Pain. Our topic today is palliative care for neurodegenerative diseases, Part 2. Objectives of this presentation: progression of neurologic diseases, prognosis, multiple sclerosis, amyotrophic lateral sclerosis, Parkinson disease, stiff person syndrome, and we will conclude with some key learning points. Progression of neurological disorders discussed in Part 1, acute progressive, chronic progressive, and chronic disability. Prognosis of neurologic diseases, also discussed in Part 1, basically is the lower part of the a picture here. It manifests as prolonged dwindling. Okay. Management of neurologic disorders, interventions to treat acute attacks, interventions that modify the course of the disease. Then we have symptom management and advanced care plan. The main symptoms in neurologic disorders are pain, spasticity, fatigue, salivary drooling, psychiatric problems such as anxiety, depression, and pseudobulbar affect, autonomic manifestations such as constipation, incontinence, and orthostatic hypotension. Advanced care planning, dysphagia such as artificial nutrition, ventilatory dysfunctions such as non-invasive positive pressure ventilation or tracheostomy mechanical ventilation, and lastly, end-of-life issues such as withholding or withdrawal of life support. We'll start with multiple sclerosis. Famous celebrities that had multiple sclerosis: Betty Cuthbert, she's an Australian athlete that won 4 Olympic medals, gold Olympic medals, and they used to call her the Golden Girl. Also, Montel Williams, who is a TV host, very famous TV host in the United States. Multiple sclerosis affect 0.1% of the whole world. So this is a common problem. It's more common in females than males. Males have worse prognosis. It has a higher incidence in Northern Europe descent, Caucasians, and in temperate climate, but the latitude gradient is decreasing. Multiple sclerosis is the most common autoimmune inflammatory demyelinating disease that share the pathological features of focal areas of degeneration of the myelin sheath that surrounds the nervous tissue. It is the most common cause of chronic disability in young adults. The process of demyelination is associated with inflammation, axon degeneration, and then gliosis. The later disease stages are driven by microglial activation and chronic neurodegeneration, which finally result in gliosis. This process leads to a wide range of clinical signs and symptoms. In Northern Europe and United States, the prevalence is about 80 to 100 per million population. It is roughly twice as common in females as in males, and the mean age of onset is around 30 years with a range of 20 to 50 years. This is a nice picture of different symptoms encountered in multiple sclerosis. You have central symptoms such as fatigue, cognitive impairment, depression, unstable mood, visual nystagmus, optic neuritis, diplopia, dysarthria, dysphagia, weakness, spasms, ataxia, pain, hypoesthesias, paresthesias, incontinence, diarrhea, and constipation. Clinical findings of multiple sclerosis on brain MRI. Picture number 1, it shows the classic optic nerve lesion seen in optic neuritis. Picture number 2, you see these ovoid lesions and also what we call Dawson fingers. Picture number 3, it shows the middle cerebellar peduncle with a hypotenuse lesion, a classic location for multiple sclerosis. So as you see, I mean, multiple sclerosis affects, variable areas in the brain. Also, multiple sclerosis has different, classifications depending on the presentation. We have the benign multiple sclerosis, we have the relapsing remitting multiple sclerosis, we have the secondary chronic progressive, and then we have the primary progressive, which affects around 10 to 20% of patients. Multiple sclerosis, nowadays, we have a host of new drugs for multiple sclerosis. Okay, we have first line, we have second line, and we have third line. First line, such as Eglati-Ramir, second line, such as natalizumab, and third line, you can see here, you have something like metoxantrone. Of course, there are new guidelines that comes out, periodically for treatment of multiple sclerosis. You should have some idea of the new medications that are used right now, just in case, you see the patient, what are you, planning to do as far as these medications. I got also very nice picture for, different symptoms in multiple sclerosis and their, treatments, such as fatigue, depression, pseudobulbar affect, cognitive impairment, trigeminal neuralgia, pain, other neuropathic pain, spasticity, neurogenic bladder, constipation, and sexual dysfunction. I had the chance as a pain physician and as a palliative physician to see many multiple sclerosis patients. And I want to say that my, overall view here, these guys, of course, when they come to you, they're usually disabled. And they have a lot of psychiatric issues going on with anxiety, depression. I mean, these people are, frustrated with their disease. They have the spasticity is one of the main issues that I encountered. And of course, usually we give, baclofen. Will start orally, and sometimes these patients need intrathecal pumps. Other medications for spasticity, tizanidine, gabapentin, dantrolene and benzodiazepines. Sometimes we do Botox injection to certain muscles. Also, the trigeminal neuralgia pain, which is usually treated with carbamazepine, oxycarbazepine, or baclofen, and sometimes they need radiofrequency. Okay. Other neuropathic pain treated with the usual gabapentinoids and TCAs. I literally seen all of these side effects, including fatigue. And in this situation, we try modafinil or methylphenidate. The other medications such as amantadine and armodafinil, which is a drug similar to modafinil, but I really haven't used these drugs. Mainly modafinil and methylphenidate. These are the ones that I use for fatigue. These folks. Of course, these patients, they need, guys, antidepressants. I mean, no doubt about it. And I usually prescribe the selective norepinephrine reuptake inhibitors. The reason is I want to get two things out of this. One of them is getting treatment of the neuropathic pain. I mean, these guys, they have neuropathy somewhere, okay, and also to help with the depression, something like duloxetine and all of that stuff. Another thing is the pseudobulbar effect, okay. And we're going to talk about pseudobulbar effect later on in the presentation, but usually we try reassurance first, and then we give the patient a medication called dextromethorphan guanidine combination. That's very famous for the pseudobulbar effect. Okay, we'll talk about amyotrophic lateral sclerosis. As we I want to also talk to you about some of the main famous characters that had this disease. Number one is Lou Gehrig, okay, and sometimes the disease is called Lou Gehrig disease. This is a very famous baseball player, okay, in the United States. Of course, he passed away, this guy. And Stephen Hawking, who's a very famous physicist in UK, and also this guy, passed away, maybe 10 years ago or something like that. Amyotrophic lateral sclerosis, or sometimes they call it Lou Gehrig disease, is the most common degenerative disorder of the motor neuron system and causes muscle weakness, increasing disability, and eventually death within 3 to 5 years after symptom onset. The prevalence in Europe and United States ranges from 2.7 and 7.4 cases per 1 million population. Most people are diagnosed after the age of 55 with the range of 39 to 80. And the incidence increase with each decade thereafter, reaching a peak in the mid-70s. While familial forms make up 5 to 10% of cases, 90 to 95% of cases are sporadic origin. So ALS affects people, older than in an older range than MS, and then you have 5 to 10% of them are familial. Okay, this is basically what you need, and it's a common disease again in the Caucasians. Like for example, here in Egypt, we don't see a lot of ALS. Okay. ALS affects the motor system, preferentially. So it affects the upper motor neuron or the lower motor neuron, but rarely it affects the sensory system. And this is the difference between ALS and MS. Okay? With ALS, you might have swallowing difficulties, whether related to upper motor neuron changes or lower motor neuron changes. You will have muscle stiffness or weakness, depending on whether the lesion is in the lower motor neuron or the upper motor neuron. Muscle twitches if it's a lower motor neuron. Okay? Overactive reflexes if it's upper motor neuron. So you get a mix of different motor manifestations, mainly motor. All right. Another nice picture for ALS. Again, Lou Gehrig disease after the famous Yankee baseball player. 90 to 95% are not inherited. 5 to 10% is familial. Men are more likely to be diagnosed than women. Okay? Amyotrophic sclerosis. Median survival is 3 to 5 years. 10% can live 10 years or more. Like this gentleman, Stephen Hawkins, he lived much longer than expected, with proper care, mechanical ventilation, appropriate artificial ventilation, they can keep you, alive for a long time. Okay, and that's what happened with, Stephen Hawkins. ALS is familial in 5% of cases. Frontotemporal dementia, this is also very important, folks. Okay, frontotemporal dementia is evident in up to 15 to 20% of patients. We talked about frontotemporal dementia in the first part of the presentation. Prognostic factors, age, site of onset. So if it manifests as bulbar symptoms, this probably has poor prognosis. The reason is this will affect your, swallowing, and it will affect your ventilation. Okay. Symptom duration. And then you have a scale, very important scale called ALS, FRS, revised. Post-vital capacity, less than 60% predicted, or rapid decline of more than 20% over 2 to 3 months. In ALS, the extraocular and sphincter muscles are spared. And this is a distinction between ALS and multiple sclerosis. Sensory examination usually is normal, generally is normal. You'll see muscle atrophy and weakness. You will see dyspnea, dysphagia, dysarthria, sleep disturbances, pseudobulbar affect, cyalorrhea, pain, cognitive impairment, and constipation, and hypoventilation. ALS, FRS revised, examines 9 domains of daily activities, plus 3 respiratory functions, and assigns scores from 0, function is absent, to 4, function is normal. Maximum scoring is 48, which is basically normal function. As you see, bulbar, fine motor, gross motor, and breathing. Bulbar, speech, salivation, swallowing. Fine motor, such as handwriting, cutting food, handling utensils, dressing, hygiene. Gross motor, turning in bed, adjusting bedclothes, walking, climbing stairs, breathing orthopnea, dyspnea, and use of mechanical ventilation. ALS-FRS revised has been validated over the past 10 years in many studies, sensitive to changes in patient condition, tracks with disease progression milestones. And accordingly to some research, it declines approximately 1 point per month in ALS patients. Medications used in ALS. There are two drugs. One of them is riluzole or Rilutec, which works by blocking presynaptic sodium channels and reducing NMDA activation. It is used to prolong lifespan of patients with amyotrophic lateral sclerosis by 3 months. And the second drug that's FDA approved for ALS is edaravone, which is an injection. All right, it's an antioxidant. It's an intravenous infusion taken, 60 milligram over 60 minutes for 14 days, then 14 days rest, and then it actually found that it can slow the progress of ALS by an average of 2 points on the ALS-FRS-R scale. So these two drugs, riluzole and edaravone, these are the only two drugs FDA approved for treatment of ALS. Okay. The third drug is, which is basically dextromethorphan plus quinidine. This drug is for the symptom management, for the side effects, the sialorrhea or the salivary drooling. Okay, I'm sorry, this drug is dextromethorphan and quinidine is for the pseudobulbar affect. Not for sialorrhea. Dextromethorphan and quinidine sulfate is used for pseudobulbar affect. Okay, we'll jump into Parkinson's disease. Again, famous celebrities such as Muhammad Ali, famous boxing player, and Michael Fox, who is an actor, had Parkinson. Parkinson's disease is a progressive neurodegenerative disease defined by depigmentation, neuronal loss, and gliosis, particularly in the substantia nigra. So the main lesion is in the substantia nigra. Parkinson's disease is recognized as one of the most common neurological disorders, affecting approximately 1% of individuals older than 60 years. The incidence of Parkinson's disease has been estimated to be 4.5 to 21 cases per 100,000 population per year. Younger patients do better than older patients with an expected prognosis of 20 to 30 years when motor manifestations can be controlled by drugs and neurosurgical procedures such as deep brain stimulation. Caregiver burden, loss of identity, and decreased social interaction all have a psychological impact on the patient and the family. Depression is more common in older patients and complicates at least 20% of such cases, rising with an increasing age of onset. When discussing advanced directives, attention should be given to artificial feeding. A PEG tube may become medically indicated, but may not improve survival or quality of life. Again, what is Parkinson's disease? And as you see here, it's a common disease. It affects 1 million people in the United States, 5 million worldwide. The diagnosis is clinical for Parkinson's disease. What is Parkinson plus then? So we have to explain this because this is also an important issue. The lack of dopamine leads to major dysregulation in the basal ganglia, resulting in a syndrome defined by rest tremors, rigidity, bradykinesia, and postural instability. This is Parkinson's disease. Okay? And again, the diagnosis is made based on clinical observation. There are no tests for Parkinson, and the presence of positive response to levodopa and other dopaminergic therapies. There are other Parkinson-like diseases that are not responsive to dopamine and may be more rapidly progressing. For example, hallucinations and cognitive decline is seen with dementia with Lewy body. Also, progressive supranuclear palsy characterized by restricted upgaze. Also, multiple systems atrophy, manifesting as autonomic failure. And lastly, symptoms of corticobasal syndrome, such as apraxia, alien limb syndrome, and frontal deficits, besides extrapyramidal motor symptoms and myoclonus. Parkinsonism is divided into Parkinson's disease and Parkinson plus disorder. Of course, Parkinson's disease is the most common form, but you should be aware about the other diseases as well because you might encounter them, such as progressive supranuclear palsy, corticobasal degeneration, multiple system atrophy, dementia with Lewy bodies. This is basically the pathophysiology of Parkinson's disease. As you see, there are two forms. There's a genetic form and there's a non-genetic inheritance. Okay, the genetic forms, it's usually affecting what we call alpha-synuclein. Okay, and this can give you the familial Parkinson's disease. All right, and the non-genetic is usually related to oxidative stress. You see also in the upper part here of the picture, dopaminergic neuron loss in the substantia nigra. And you see also Lewy bodies, okay, with alpha-synuclein aggregates. So that's in short the pathophysiology of Parkinson's disease. Clinical manifestations of Parkinson's disease: rest, tremors, rigidity, bradykinesia and postural instability, cognitive dysfunction, depression, orthostatic hypotension, bladder symptoms such as constipation, mask face, pain, sleep disturbances, fatigue, and sialorrhea. Parkinson's disease symptoms. Again, this is a very nice picture. Mask face, forward tilt of the trunk, reduced arm swing, hand tremors, slightly flexed hip and knees, shuffling or short step gait, flexed elbows and wrists, back rigidity, and stooped posture. Parkinson's disease goes into different stages. prodromal, early stage, mid stage, and late stage. Prodromal, you see onset of motor symptoms. Usually, by the time you reach the early stage, you get this triad of bradykinesia, rigidity, and tremors. And then in the mid stages, you see fluctuations and dyskinesia. And in at last late stages, you start to have nutritional problems because of dysphagia, falls, axial deformities, and postural instability and gait disorders. Um, and this is important to to know which stage, because according to the stage, you start to think about stuff like a DBS, deep brain stimulation. Treatment for Parkinson's disease, we have again the dopamine precursors, such as levodopa, precursors, cinnamate, levodopa carbidopa, and non-ergot dopamine receptor agonists such as pramipixole, ropinirole, and others. MAO-B inhibitors such as silogeline, COMT inhibitors such as entacapone, amantadine, and there are medications that you need to avoid in these situations. This is a very nice, wrap to all medications for Parkinson's disease. We're not going to go through all of these because this is outside the scope of our presentation. But I just want you to have an idea. When a Parkinson's disease patient comes to your clinic as a pain or as a palliative physician, okay, you need to have an idea about these medications that he's using. Also, deep brain stimulation is another way to deal with, Parkinson's disease. And right now, this is commonly done, usually by a neurosurgeon specialist. We call them functional neurosurgeons. All right, and these are not, commonly found all over the world. I mean, usually, in each country, you'll find like very few people that do this kind of surgery. Okay. The last topic here would be the stiff person syndrome. This is a rare disease, not like other diseases that we talked about. Okay. But it had brought some attention to the media because of one of the famous singers got affected with stiff person syndrome. So that's why I put it in my presentation. And also, I had a chance to see one case during my life time here, and this patient was very dear to me. So that's why I like to, share it with you guys. So it's a rare progressive syndrome that affects nervous system, specifically the brain and spinal cord. Symptoms may include extreme muscle stiffness, the name is stiff person syndrome, rigidity and painful spasms in the trunk, limbs, and severely impairing mobility. Spasms can generate enough force to fracture bones. People with stiff person syndrome have heightened sensitivity to noise, sudden movements, and emotional distress, which can set off muscle spasms, Persistent symptoms can lead to abnormal posturing of the spine, such as being hunched over. The syndrome affects twice as many women as men. SPS is caused by increased muscle activity due to decreased inhibition of the central nervous system. It is thought to have autoimmune component and is often associated with diabetes, as well as other autoimmune diseases such as thyroiditis, vitiligo, and pernicious anemia. So these are this disease is a little bit different than the other ones that we talked about. First, it's rare. Also, it's characterized mainly by stiffness all over the body. And also, it could be associated with other autoimmune disorders, such as thyroiditis, vitiligo, and pernicious anemia. So, this disease has affected this Canadian, super famous Canadian singer, Celine Dion. As you can see her picture before and after. Stiff person syndrome may be diagnosed after having various tests. So this disease has a test, okay? Not like Parkinson disease. It has a blood test where they check the glutamic acid decarboxylase antibodies, the GADs, okay? Glutamic acid decarboxylase antibodies, which is elevated in 2 to 3 people of SPS. A lumbar puncture and electromyography is also needed. Progression of SPS depends on whether it is typical or abnormal form of the condition and the presence of comorbidities. Early recognition and neurological treatment can limit its progression. SPS is generally responsive to treatment, but the condition usually progresses and stabilizes periodically usually progresses and stabilizes periodically by metabolic acidosis or autonomic crisis. Even with treatment, quality of life generally declines as stiffness precludes many activities. Some patients require mobility aids due to risk of falls. About 65% of SPS patients are unable to function independently. About 10% of SPS require intensive care. At some point, sudden death occurs in about the same number of patients. These deaths are usually caused by metabolic acidosis or an autonomic crisis. Stiff person syndrome. It's a rare neurological disorder. Affects 1 in a million people. Affects twice as many women as men. Age of onset 30 to 60 years. Associated with diabetes, thyroiditis, vitiligo, and pernicious anemia. Symptoms are muscle stiffness, spasms, increased sensitivity to noise and touch. Diagnosed by history and clinical examination. Treated by benzodiazepines, anti-seizure medications. Complications are emotional disturbances and frequent falls. Symptom management. We're going to talk about symptom management for all the diseases right now. Pooled evidence suggests that 63% of MS patients and 75% of people with ALS and Parkinson's disease experience neuropathic pain, although there is no evidence of sensory involvement in ALS patients. So this is kind of an interesting phenomenon. Pain experienced in MS can arise from neurogenic sources, paroxysmal pain or neuropathic pain, and also non-neurogenic such as musculoskeletal or soft tissue pain. The latter is often overlooked with neurodegenerative disorders and may be a result of immobility in combination with muscle weakness. It's also the result of spasticity, gait disturbances, and poor sitting posture. Most of the time, we give muscle relaxants to patients with MS because of the spasticity, like tizanidine. We give also gabapentinoids. We give also, sometimes dantrolene, um, baclofen. Of course, this is one of the first choices. Um, as we said, sometimes we do, if it's a localized problem, we can do some Botox injection. In severe cases of spasticity, you might need to do a baclofen pump. Joint pain may be exacerbated by the loss of protective muscle sheath or abnormal tone. Appropriate involvement of physiotherapists and occupational therapists in conjunction with NSAIDs can be beneficial. In addition, patients with limited mobility are more prone to develop pain secondary to skin pressure and skin breakdown, resulting in neuropathic pain. Pain in Parkinson's disease, usually musculoskeletal related to rigidity, posture, dystonia, and dyskinesia. It could be also visceral, related to constipation or central pain. Pain is one of the most undertreated symptoms of Parkinson's disease. All the neurodegenerative disorders can result in muscle cramps, spasms, and spasticity. In MS, however, spasticity is one of the most typical and debilitating symptoms. Spasticity can lead to pain, spasms, reduced mobility, limited range of motion, as well as contractures. When treating spasticity in a person who is still able to bear weight, special consideration must be to give must be given to maintaining muscle tone. So you don't want to overtreat because you need to have some muscle tone in the patient. Again, the classic medications used are baclofen, benzos, dantrolene, also tizanidine is an important drug. Besides gabapentin, it has a muscle relaxant activity. So we usually use like a mix of these medications. We always start with baclofen, of course. This is our first choice. Okay, spasticity, any number of preventable stressors such as cold, full bladder, stretching, overexertion, and infection can initiate spasms and should be avoided. The extensive spasm they are experiencing in their lower limbs may be the reason they can still perform weight-bearing activities as it compensates for the loss of strength. So sometimes the spasticity can be helpful in a sense that you be able to do a weight bearing in your lower extremities by having an external muscle spasm, extensor muscle spasm. Spasticity also is associated with flexor spasm triggered by touch of movement. These spasms can be extremely painful. If only a few muscle groups are affected, local injection of Botox has been shown to be helpful, especially when combined with post-injection physiotherapy and stretching. Intrathecal baclofen pumps are useful for patients with severe spasticity that is difficult to manage with oral drugs alone. Botox or botulinum toxin A, this is one type. That we have type A, type B. Baclofen, and again, this is a baclofen pump. What we usually do is we bring the patient to the clinic and we do one intrathecal shot of baclofen, around 50 mics, okay, intrathecal, and see how it works. We use something called Ashworth scale. Once you do Ashworth scale and see the results, you decide on putting a pump in. This is how it looks like. It's exactly like a pain pump. Same thing. The only difference is the medication. You'll be using baclofen instead of morphine. Okay, how about salivary drooling? The inability to swallow patients' own saliva may result from a specific bulbar palsy that occur most commonly in ALS. So this salivary drooling phenomenon, we see it a lot in ALS patients. So we have, of course, the first thing you will notice when an ALS patient coming to you, to your clinic, he will be bringing his own, suction machine with him, suctioning this saliva coming out of his mouth here. Also, you can use anticholinergic drugs such as hyoscine, glycopyrrolate, atropine, or even amitriptyline. And those patients that do not respond, you can try injecting botulinum toxin. Again, another indication for botulinum toxin, not just for spasticity. The second indication here is for salivary drooling. Injecting botulinum toxin in the parotid and submandibular glands has been shown to be beneficial. Again, some of the medications we use, anticholinergic effects, glycopyrrolate, hyoscyamine, oral drops, scopolamine patch. I myself, I like using scopolamine patch, okay, because with the glycopyrrolate tablets or this is just you put it there and you just change it every 3 days. This is you put it behind the ear and you change it every 3 days. It's very convenient. All right, and then you have amitriptyline, which is a TCA, but it has an anticholinergic effect. Again, botulinum toxin injected in the parotid can be helpful. Also, a suction machine, a good suction machine, portable suction machine is very useful in these situations. Symptom management, psychiatric. I want to talk about pseudobulbar affect, as I promised you at the beginning of the lecture here. It's also described as emotional lability or emotional incontinence. So what is pseudobulbar affect? It describes a sudden, uncontrollable outburst of laughter or tearfulness and affects 20 to 50% of patients with ALS and has an increased prevalence in MS as well as in stroke patients. So how we treat this pseudobulbar affect? Of course, as we mentioned before, reassurance is important, okay? Kind of explain to the family as well what's going on so they don't get scared about it. Also, there is a drug used for this situation. It's called dextromethorphan quinidine. All right, and we talked about it earlier. So dextromethorphan quinidine is a drug of choice for pseudobulbar affect. It's been shown to reduce the frequency and the severity of these spells and improve quality of life. Okay, hallucinations could be also bothersome to patients and family. And the only drug FDA approved for these hallucinations is pimavanserin. And also we can use quetiapine, but remember that antipsychotics carry a black box warning for increased risk of death in elderly folks. Autonomic manifestations. Bowel and bladder are usually involved in late stages of neurodegenerative disorders. You might see a constipation. Also, this could be exacerbated by poor dietary intake or medication side effects or limited mobility and decreased intake of fluids for fear of urinary incontinence. When using aperients and isomolar osmolar drugs such as polyethylene glycol is preferable to lactate. Stimulants such as senna may be required. Dosing should be scheduled rather than as needed. Rigorous bowel management, including occasional suppositories, is crucial to avoid infection. Enemas and manual evacuation may become necessary otherwise. Other manifestations, autonomic manifestations, is orthostatic hypotension, which accompanies advanced Parkinson disease. Non-pharmacologic means such as increased fluid intake, abdominal binders, and compression stockings should be implemented. Midodrine, fludrocortisone, and droxidopa are all helpful at increasing blood pressure. All right, we're gonna jump into the advanced care planning for neurodegenerative disorders. The most important one is the feeding. Many patients develop a degree of dysphagia, while less than 50% of patients of MS are estimated to have swallowing problems. More than 50% of Parkinson's disease and the majority of ALS patients develop swallowing difficulties. Swallowing difficulties can lead to malnutrition and weight loss, which is identified as a risk factor for survival. The goal is to maintain nutrition by the oral route as long as possible. This period may be extended by appropriate eating aids, neck positioning, and oral food supplements. However, there's an important to be aware of optimal timing for placement of a tube to initiate artificial feeding. The placement of a PEG tube has been shown to stabilize body weight and may prolong patients' survival in ALS. So usually you start with oral feeding. You try to maximize the time frame as much as you can. At a certain point, you're gonna have to switch to a PEG tube. In acute neurologic injuries such as stroke, artificial feeding is used as a bridge therapy while awaiting clinical improvement. On the other hand, there is no clear evidence that artificial feeding increases quality of life in patients with progressive neurodegenerative disorders. Regular assessment of oral intake and swallow function should be undertaken by a multi-professional team. Nasogastric tube, PEG tube. The second part of advanced care planning is ventilation. Neurodegenerative disorders can lead to hypoventilation, especially ALS. Most deaths from ALS are caused by respiratory failure. Dysphagia is expected as the weakness progresses. Insertion of a PEG tube is recommended for supplemental nutrition before respiratory function declines. So usually when this patient comes to you in the palliative care clinic, you need to start discussing, both ventilation and nutrition. First, we'll start with the nutrition because this is the easiest part, inserting a PEG tube. Okay, but you have to discuss both of them in the same setting. All right, so they understand the situation and understand that this will prolong their life. All right, some patients, by the way, they refuse. And in this situations, of course, you know, they will have a limited life expectancy. Um, so studies have shown that non-invasive positive pressure ventilation improves life expectancy and quality of life in patients with a forced vital capacity of less than 50. Patients who use non-invasive uh, positive pressure ventilation live an average of several months longer than those who don't. In addition, improving survival, non-invasive positive pressure ventilation have been shown to decrease dyspnea, daytime fatigue, and insomnia. These patients may persist even as the disease continues to progress. And this is what happened with a guy like Stephen Hawkins, for example. He, had, PEC tube and he had artificial ventilation, and he was able to live for a long life after he had ALS. Invasive ventilation via tracheostomy may be indicated for those with intractable sialorrhea or as an emergent situation where goals are not clear. A false vital capacity of less than 50 is frequently associated with respiratory symptoms such as daytime fatigue and somnolence, depression, anxiety, morning headache, reduced appetite, and weight loss, besides of disturbed sleep and nightmares. A further reduction of forced vital capacity to less than 25 to 30% is linked to a significant increase of risk for respiratory failure or sudden death. Non-invasive positive pressure ventilation, this includes CPAP and BiPAP. Tracheostomy, mechanical ventilation. Okay, we'll talk about hospice eligibility for neurodegenerative disorders. The patient must meet at least one of the following criteria: critically impaired breathing capacity, manifested as dyspnea at rest, vital capacity less than 30%, need oxygen at rest, patient refuses artificial ventilation, or rapid disease progression with either progression from independent ambulation to wheelchair or bedbound status, normal to barely intelligible or unintelligible speech, normal to pureed diet, independence in most ADLs, to needing major assistance in all ADLs. Okay? And critical nutritional impairment demonstrated by all of the following in the preceding 12 months: oral intake of nutrients or fluids insufficient to sustain life, continuing weight loss, dehydration or hypovolemia, absence of artificial feeding methods, or B, life-threatening complications in the past 12 months, such as recurrent aspiration pneumonia, pyelonephritis, sepsis, recurrent fever, or stage 3 or 4 pressure ulcers. Okay, I would like to just, wrap this up. So I want to think about neurologic disease. The two biggest here are nutrition and ventilation. So these, if they are really affected, probably these patients will need hospice. Also, if these patients, have life-threatening complications, they have recurrent life-threatening complications, such as pneumonias, pyelonephritis, sepsis, and all of that stuff. Stage 3 or 4 pressure ulcers. This actually supports your, decision for hospice eligibility. Lastly, we're going to talk about the role of palliative medicine in neurodegenerative diseases. This is just a quick wrap for all what we said. Breaking bad news, psychological help, symptomatic treatment, PEG feeding, home ventilation, end-of-life decisions, terminal phase and death, and lastly, bereavement counseling. Key learning points of this presentation: there is a need for symptom control, psychosocial support, and help with advanced planning and end-of-life decision-making in patients with neurodegenerative disorders, while there are particular challenges with newly diagnosed patients due to unpredictable disease course, neurodegenerative disorders in the advanced stages, amyotrophic lateral sclerosis, end-stage Parkinson disease, and secondary progressive multiple sclerosis do have a predictable course of progression. Palliative care should be involved early and continuously. Patients with neurological diseases are prone to fatigue, communication difficulties, and decreased mobility. All of these factors affect their ability to participate in psychosocial support and counseling. While there's no cure for neurodegenerative disorders, there are particular treatment options that decrease the burden of symptoms and help to maintain the quality of life of patients and caregivers. Thank you.